Delighted to be here today to present my research, which aims to answer a rather big question, namely if we can offset a high genetic risk of prostate cancer by adherence to a healthy lifestyle. And I've been working with this question for a little more than 2 years now, and I'm far from having a definite answer, but we have made several interesting observations that I want to share with you today. And I got interested into this question after realizing that we are now in, I would say, a unique position of being able to identify men at high genetic risk for prostate cancer. And this is what the first part of my presentation will cover. So the genetic contribution to prostate cancer risk is well established. We know that men with an affected first-degree relative, they have 1.5 to 2-fold increased risk of developing prostate cancer. And this risk is even higher if a man has more than one affected relative. And prostate cancer is one of the most heritable cancers. And this graph gives some heritability estimates for different cancer types with prostate cancer to the very right. And in red, we can see the classical twin study estimates, which is approaching 60% for prostate cancer, meaning that close to 60% of the variability in prostate cancer incidence can be explained by genetic factors. And in blue is the heritability we can currently measure with genotype data. And for prostate cancer, we think that the majority of genetic risk or heritability is yet to be discovered. But with that said, it appears that we can do a lot of things with what we already know. So there's been a lot of work in developing polygenic risk scores for prostate cancer. And polygenic risk scores, they capture genetic susceptibility for prostate cancer arising from common genetic variants and measure the cumulative impact of those variants. And the latest polygenic risk score for prostate cancer from the Prostate Cancer Genetics Consortium Practical includes 269 genetic variants identified in trans-ST analysis. And we have seen now in multiple studies performed in different populations how well this polygenic risk score can predict lifetime risk of prostate cancer. Among men with a high polygenic risk score, the lifetime risk of prostate cancer is around 50%, compared with less than 5 to 10% among men with a low polygenic risk score, which is illustrated here in these figures. In addition to genetic risk capture by common variants included in polygenic risk scores, prostate cancer risk is also influenced by rare genetic variants. And in particular, rare inherited genetic variants in DNA repair genes have been found to increase the risk of prostate cancer and also the risk of prostate cancer progression. And BRCA2 is one of these genes, but several other genes also appear to be relevant. And in an analysis presented in the figure at the bottom, we compare the frequency of DNA repair gene alterations between lethal and indolent prostate cancer cases. And also when BRCA2 is excluded, lethal cases had a higher frequency of DNA repair gene alteration, and this was consistent across the two ancestry groups presented here. And what happens if we combine different measures of genetic risk, not unsurprisingly perhaps, but we get a better measure. So these two figures shows the lifetime risk of prostate cancer in BRCA1 and BRCA2 carriers. And as you can see, the risk of prostate cancer is not the same for all carriers. Men who carry an alteration and has a high polygenic risk score, they have a substantially higher lifetime risk than men who carry an alteration but have a low polygenic risk score. And there is a further measure we can integrate with the polygenic risk score, and that's family history of cancer. So family history is not a direct measurement of genetic risk, but it appears to capture at least some of the genetic risk we cannot measure with the polygenic risk score. And it can perhaps capture some of the rare alterations that we have not yet discovered, but are potentially relevant in prostate cancer etiology. So this is data from an analysis in the Health Professionals Follow-up study. And similar to the previous analysis, we observed the highest lifetime risk of prostate cancer among men with a high polygenic risk score and a family history of either prostate or breast cancer. And the same pattern was observed for prostate cancer death. So by combining different measures, ideally all three, the polygenic risk score, rare variants, and family history, we can stratify men according to risk of not only prostate cancer, but also prostate cancer death. And one thing that we observed in this analysis was that men with a high polygenic risk score, that is above the median, or a family history, they accounted for nearly all prostate cancer deaths. So by age 75 years, 32 out of 33 prostate cancer deaths, corresponding to 97% of the total risk, occurred in the PRS 50 to 100 group or among men who had a family history of prostate or breast cancer. And it's important here to note that this group is around 60% of the population. So we would expect more deaths in this group, even if there were no link between the two. But there is a clear excess risk among men with a high polygenic risk score or a family history of cancer. And an important message here is also that around 40% of men may have a low to no risk of dying from prostate cancer before age 75 years. And what now? I think we can expect genetic testing to be widespread in the next 5 to 10 years, and many more men will find out that they have a high polygenic risk scores and are at increased genetic risk. But the current recommendations for screening, etc., are not including this, and it's unclear how this should be approached. So currently we have some screening guidelines for men with particular gene alterations, and there are also some treatment regimens that are of particular benefit for men with certain DNA repair gene alterations. But as I said, polygenic risk is not included, and there are also no clear recommendation on other preventive measures such as lifestyle and diet. And that brings me to the second part of this presentation. Can a healthy lifestyle compensate for a high genetic risk? Until now, there are only limited data integrating genetic and lifestyle information. However, previous studies, they support a general role of a healthy lifestyle in prostate cancer prevention. And here is a table listing some of the most studied risk factors and the most likely direction of effect. So numerous observational studies, they have indicated that obese men have a greater risk of developing more aggressive prostate cancer, experience disease recurrence, and dying of prostate cancer. And substantial data also support that smoking is associated with an increased risk of advanced disease. In addition, studies have reported an inverse association between vigorous physical activity and certain components of a healthy diet with the risk of advanced disease. And we performed the first study integrating the polygenic risk score with lifestyle factors. And this study included genotyped men from the Health Professionals Follow-up Study, HPFS, and the Physicians Health Study, PHS. And around 12,000 men in these cohorts have been genotyped to date, and they could be included in the present analysis. And there were around 3,000 prostate cancer and 400 lethal events. And exposure was the latest polygenic risk score and a healthy lifestyle score previously developed for lethal prostate cancer, which I will describe in a second. And since we made use of data from multiple nested case control studies within these cohorts, we ran inverse probability weighted Cox regression models to take potential sampling bias into account. So the healthy lifestyle score, we used a score that has been previously developed in these cohorts, and it includes the 6 components listed here: a healthy weight, vigorous physical activity, not smoking, and a healthy diet consisting of a high consumption of tomatoes and fatty fish and a low consumption of processed meat. And all of these components were assigned 1 point each if fulfilled, meaning that 0 was the lowest and 6 the highest score. And for this analysis, we grouped men into unhealthy, moderate, and healthy. The main finding of this study was that among men at highest genetic risk, we observed that adhering to a healthy lifestyle was associated with a reduced risk of lethal disease. And the table shows the adjusted hazard ratios. For overall prostate cancer, we did not see any association, but for lethal disease, the rate was 45% lower among men with a healthy lifestyle. And these results are actually in agreement with previous research not involving genetics, which has not found a clear relationship between lifestyle factors and overall prostate cancer risk, but a much more consistent pattern for lifestyle factors and more aggressive disease. And the figure shows the absolute risk of lethal disease according to lifestyle score, but this figure is unadjusted for other factors except for age. A major question in this analysis is whether these results can be explained by other factors associated with a healthy lifestyle. Healthy men could have more frequent PSA screening or better diagnostic workup or treatment. And this is something we also observed in the available data. As you can see in this graph, men in the healthy category, they were more likely to have had a PSA test at study entry, and also slightly more likely to have undergone curative surgery. But the difference in healthy lifestyle characteristics between the groups were much more pronounced. Here you can see the percentage for high vigorous physical activity, which was over 60% in the most healthy group and very low in the unhealthy group. So the lifestyle groups are much more extreme when it comes to the actual lifestyles than these other factors, which makes me believe that some of the effect that we see here, maybe not all, go through potentially some biological mechanisms rather than early detection and treatment. And we also try to account for these differences in adjusted analysis with similar results that you can see in this table. And even if the exact mechanism is not clear, I think it is of interest to know that the high genetic risk of prostate cancer death may be modifiable by some means. I'm involved in 2 ongoing validation of these results, and this is one of them. And this is preliminary data from the Million Veteran Program. In this analysis, a healthy lifestyle score, including smoking, BMI, and physical activity, was examined. And as you can see in the figure to the right, a low HLS, that is a more unhealthy lifestyle, was associated with a higher risk of metastatic prostate cancer. And in the figure to the right, the same comparison is made, but now restricted to men at highest genetic risk. And PHS is a polygenic hazard score, which is very similar to the polygenic risk score I presented previously, but the weights are slightly different, and also the variants are also included are also slightly different. So these results indicate the same thing as we observed in HPFS and PHS. This data did also allow for stratification by self-reported race ethnicity. And this graph shows the higher incidence of prostate cancer, metastatic disease, and fatal prostate cancer among men self-reporting as Black, that's the green curves. Also among Black men, a healthy lifestyle was associated with a reduced risk of metastatic disease. And for overall prostate cancer, we see the same pattern as in HPFS with no major difference. And for fatal prostate cancer, the analysis was somewhat limited by fewer events, although the pattern is the same as for metastatic disease. So this suggests that lifestyle factors are important irrespectively of race. I have another ongoing validation, and that is among Scandinavian men. And this analysis included around 10,000 men followed from the early 90s for prostate cancer death. And here we used the same lifestyle score and polygenic risk scores as before, but now in a slightly different combination. And we combined family history with the polygenic risk score to capture more of the underlying genetic risk, and we combined the moderate and healthy categories based on their similarities in the previous analysis. And we observed similar estimates as in HPFS and PHS, with the highest risk of dying from prostate cancer among men with a high genetic risk and an unhealthy lifestyle. And among men at low genetic risk, the same pattern was observed, but somewhat less pronounced. We are also trying to understand the role of the individual lifestyle factors included in the score. It may not be possible to fully disentangle them because of their correlation, but this table gives an idea of their contribution. So among men at high genetic risk, smoking and obesity appear to contribute to an early death from prostate cancer, and low levels of physical activity and a poor diet may also contribute. Before I conclude my presentation, I would like to mention some of the follow-up projects we plan. So we want to understand the mechanisms behind these observations. And one thing we plan to do is to integrate the genetic and lifestyle data with other molecular data, for example, biomarkers, to see if we can get a better idea of the underlying biology. And we are also interested if there are specific gene environment interactions involved here, but for that we need robust data from multiple studies to avoid false positive findings, which has otherwise been a problem in this area. We also have ongoing analysis examining if specific diets could be a benefit for men at high genetic risk. And we're also interested in understanding the optimal time point for a lifestyle adaptation. And does it have to be early in life, or can an intervention post-diagnosis provide a benefit? I would like to conclude my presentation with the following. So thanks to substantial research advancements in the last 10 to 20 years, we are now in a unique position of being able to identify men at high genetic risk. And based on the data I presented here today, we now have some support that the high genetic risk of prostate cancer is not deterministic for a poor prostate cancer outcome, and adherence to a healthy lifestyle or something associated with a healthy lifestyle that cannot be ruled out may provide a way to reduce a high genetic risk. And finally, I would like to acknowledge the funding sources and all of my fantastic co-authors and co-investigators. Thank you very much for listening.
Thank you, Bert. Thank you to you and Stefania for inviting me into your Friday weekly groups. So I'm happy today to talk about some of the research I've been working on the last few months. As you mentioned, racial and ethnic disparities between outdoor or ambient PM2.5 and stillbirth among Medicaid enrollees. So PM2.5 is one of the main metrics we use to characterize pollution. It's a term for particles that are less than 2.5 microns. These are about 1/20th the size of a human hair, so you can't see them. But because they're so small, they can travel further into your lungs and cross over into your blood. So they're the ones that can cause respiratory problems, asthma, but also cardiovascular problems. And there's also research showing pregnancy, adverse pregnancy outcomes. And so there's a lot of different components of PM in terms of particles, nitrates, and sulfates, but we're using that as an overall metric. And the EPA, Environmental Protection Agency in the US, has established these national ambient air quality standards, which we call NAAQS. And they have set standards for PM. It's one of the pollutants they regulate in the US. And their current standard for PM annually is less than 12 micrograms per cubic meter. And I'll discuss this later on, this metric. And the specific outcome we're investigating in this particular study is stillbirth, which is the fetal death that happens over at 20 weeks of gestation or later. In the US, it's rare, less than 1% of births. It's more common in other low and middle income countries, but less common in the US. But however, if the stillbirth does occur, it's obviously a huge psychological and emotional burden for the families. It also has a burden on healthcare because of the large expenses. There's an idea of some potential causes, but in a lot of cases it's uncertain. There's also a lot of studies showing that there's various modifiable risk factors and also environmental risk factors. And one of them is potentially air pollution. And so the potential mechanisms for the relationship between air pollution, specifically PM2.5 and stillbirth, there's a few potential mechanisms related to inflammation and oxidative stress, then can cross over to placenta and have impacts. For this study, we won't get into those details, but there is a lot of literature on potential associations. And so in this particular study, we're looking at PM2.5 and stillbirth in the United States, and previous studies have had mixed results. So some have found an association and some have not. And there could be various reasons for this. So studies are conducted in specific states. So the population demographic could be very different. PM2.5 levels also vary spatially and temporally, which means in a very short distance, the air pollution can vary depending, for example, how close you are to a road or fossil fuel plant or other source. In addition, over time, PM2.5 levels can also vary. So I have this graph here in the middle of the slide, and this is actually from a paper that other researchers in the Department of Environmental Health worked on, but this is showing at a national level the average PM2.5 level. So you can see it's actually decreased quite a bit over the last 2 decades, thanks to air pollution regulations. But then within each year, you see there's substantial seasonal variation. And so this is just at a national level. So you can imagine at a very small level, at zip code or neighborhood, you also see even more variation as this is averaged over the entire country. And so previous studies have looked at air pollution levels over the entire length of pregnancy or one trimester, maybe the third trimester. And there's also short-term effects. So that could also lead to differences in findings. And so our study is actually looking nationally. And so we're one of the first to look at this. We specifically have a large sample to look at by different races and ethnicities. And so we're specifically looking at whether a short-term change in air pollution can trigger a stillbirth. So we're talking about an average over the week, essentially the week prior to a stillbirth in the past few days. So our averaging period is a lot smaller than a trimester or entire pregnancy. And so in this study, we're answering the question if short-term increases in ambient PM2.5 are associated with higher odds of stillbirth. To conduct this study, we used a time stratified case crossover design, which is a way of saying that every case is acting as its own control. So what this means is selecting control periods or other days and comparing the PM2.5 levels on those control days to the actual case day. So the image at the bottom is kind of showing this selection. So we use something called symmetric bidirectional sampling, which means that you're selecting control days before and after the case day. So if you have a stillbirth that occurs on a specific day, you can look at 1 week before as your control period, 2 weeks before, 1 week after, and 2 weeks after. And you can select control periods after the day of the event. Even though the stillbirth has occurred, the air pollution level isn't affected by that, so it's independent. So this is why this sampling strategy works well. And so we can compare within an individual if the air pollution level during the day or days preceding the stillbirth was a trigger for the event. And we selected days specifically 1 and 2 weeks before to control for long-term trends in air pollution. So as I showed in the previous slide, it can air pollution can vary seasonally and over a long term, like years. So by selecting our control periods within the same month, we were able to control for this as well. And so we matched the PM2.5 concentration to every case and control date by zip code. And we use conditional logistic regression for the analysis. In addition to the conditional logistic regression, to assess air pollution, we use something called a distributed lag nonlinear model. And this is basically to assess delayed effects. So just because air pollution may occur on one day, the stillbirth may actually happen several days after. And so because of this, we can assess up to a lag effect. In this case, we selected 6 days. So we can look at the relationship between an air pollution event and then the effect on stillbirth potentially up to 6 days later. And so these graphs here are taken from a previous paper citation at the bottom showing a potential relationship between relative risk of an outcome and air pollution. And you're able to account for potential nonlinear relationships. The relationship may be log linear or vary over the exposure period. And so this specific model allows us to look at those different effects. And then the data sources used, as I mentioned, this was among Medicaid enrollees, and this was taken from the MAX dataset, which stands for Medicaid Analytic Extract. And so Medicaid enrollees are of lower income than the average population in the US. But Medicaid covers the expenses of almost half, or over 40% of births in the country. And we had data in the MAX dataset from 2000 to 2014. And the dataset also included information on race, ethnicity, maternal age, and the zip code that they lived during pregnancy. And the census, we also extracted median household income at a zip code level, which I'll discuss later. And for the exposure data for PM2.5 exposures, we had data from previous study with the citation at the bottom of 1 kilometer grids across the US. So basically for every area in the United States at 1 kilometer resolution, we had a daily average PM2.5 value. But because the data from our Medicaid MAX dataset was aggregated at a zip code level, we then took the average in each zip code, so the average daily PM2.5 level. And this information on air pollution used a variety of sources. So there's information from satellites to measure something called aerosol optical depth, chemical transport, land use regression. So a lot of different factors went into these machine learning models to estimate the air pollution levels at a small geographic resolution. So then moving to the results. So this is showing the distribution of stillbirths from 2000 to 2014 in our data set. There were a total of about 112,000. The majority were white or black, so each making up a third of the data set, and then a smaller proportion were Hispanic, Asian, or American Indian. And this is showing the distribution, and you could see that there's a lot more variation among white and black, whereas some of the other less common race ethnicities are more concentrated in specific areas. I thought it'd be useful to show the distribution of PM 2.5 here at the top. So this is how PM 2.5, the average concentration on the days of stillbirth over the entire study period. And I'm referring back to the ambient air quality guideline, which is 12 micrograms per cubic meter as a reference point. And so most of the air pollution levels actually fell below this, which is a good sign, but you can see there is variation by race and ethnicity. So if you can make out from the graph in yellow, for example, is Black individuals, you could see the tail here is longer. So on average, they're exposed to slightly higher PM 2.5 levels. American Indian individuals had the lowest exposure on average. And so there was a slight difference in distribution, and the right tail kind of expanded over 12. And then looking at the bottom in terms of the median levels, basically just showing the graph at the top by the median and interquartile range. Black individuals had about 1 microgram per cubic meter higher average concentration over the entire study period compared with whites and Hispanics, the other two most common races and ethnicities. So then looking at a national level, the results from the association between PM 2.5 and stillbirth. And so our exposure is a 10 microgram per cubic meter increase. And so looking over the 6 different lag days, there was a significant association basically on the immediate day, or lag 0. And I'll mention that our lag 0 in this case is actually 2 days before the stillbirth. So everything is subtracted from 2, because the research has shown that it can take up to 48 hours for the actual stillbirth. So lag 0 is on that day, and then up to a 6-day lag. And we saw a significant association at lag 0 and lag 4 in the unadjusted model, but we controlled for potential time varying exposure. So temperature can vary within the span of a week. So that's not accounted for in the case crossover design. So we controlled for temperature and found that the association was still significant at lag 4. And we also adjusted for other co-pollutants, so nitrogen dioxide and ozone. And we also had a significant association at 4 lag days. And then we stratified the results by different factors such as race and age. And so this is matching with previous studies. So we see here at the top in red is by age, and I have the yellow line vertically is the average at lag 0 from the previous slide. So you can see that those with higher maternal age or more advanced maternal age, 30 and above, had higher risk of stillbirth associated with an increase in PM 2.5. And so we had because our study population was much younger, our sample size among 40 was quite small, and that's why you see that wide confidence interval there. But those aged 30 to 40 actually had a significant association, where those below 30 did not. And similarly, a significant association was found among Black individuals. And American Indian was also elevated, but there was a smaller sample size, and so it wasn't a significant association. The association among Asians was actually the opposite, a protective effect, which has actually been found in other studies, and I may discuss potential reasons for this later on. This slide is now showing the overall lag response by each of the different races and ethnicities. So basically from lag 0 to lag 6, the association between PM2.5 and stillbirth. So if you first look among white individuals, there was no association across the entire lag period, whereas among Black individuals, there was a significant association among Black individuals from lag 0 to about lag 3. And that's shown here because the line and confidence interval does not cross 1. And this was actually the only race or ethnicity where we did find a positive association in the initial lag stages. So among Hispanic and American Indian, there was an elevated association at the beginning, but did not reach significance. And among Asian individuals, we actually see a significant negative association at lag 0 to 3, and then actually switches to positive. And so the thinking here is that there's large differences potentially in this population and the geography that they live in the US that may explain this finding. And I'll discuss this further on. And then additionally, we further stratified the 3 most common races and ethnicities in our study by median household income. And this again was taken from the census. So we combined the data sets. And so I grouped them by quartiles. So within those Medicaid enrollees, which quartile of income there's the zip code they live in was. And so we further see a modification here among Black individuals. So those living in the poorest zip codes are in the first quartile, so where the average income is less than 30,000. The association was significant, so even higher than overall among Black individuals, whereas those in higher quartiles, actually there was no significant association. So we could see here that the effect is modified within race only among Black individuals that it's higher. We don't really see as strong associations among Hispanic and white individuals. And then so moving into the strengths limitations of this study. So because of the case crossover design, we controlled for variables that maternal risk factors that may not change over time. Because every case is acting as their own control. We were able to look at nonlinear relationships and delayed relationships when the exposure lag response using the models. And so even though stillbirth is a rare outcome because we had a large data set over the 15-year period, we were able to assess these relationships by race and ethnicity. And this is one of the largest national studies to assess the relationship between air pollution and stillbirth. And so, as I mentioned, the Medicaid population is not fully representative. They're lower income and younger than the US population, but it's understudied in US epidemiological research. Most studies looking at insurance data are from private insurance or Medicare. So this allows us to look at the associations among this unique population. And because we're using air pollution at a zip code level, there's a lot of variation within zip codes. And so because of that, there may be some exposure misclassification. But even though that may attenuate the association, we still saw significant effects. And this also applies to assigning the maternal residence zip code at delivery. And so we know that, during pregnancy, they may be mobile, so their exposure may not be entirely in that zip code. But despite that, we still saw significant associations. And so then just some overall thoughts and conclusions. So in this study, we found that short-term increases in ambient PM2.5 can potentially trigger a stillbirth. And this was found among Black individuals, not among other races and ethnicities. And so because of these large differences, policymakers should consider that factoring in race and ethnicity when developing national ambient air quality standards or looking at the burden of air pollution related to stillbirth, because we see such a significant variation. Potentially another implication of this is that pregnant women should try to avoid outdoor activity during acute PM2.5 events, because as we mentioned, this can potentially trigger stillbirth. So one such example is wildfires. There's not a lot of data yet on specifically the air pollution from wildfire smoke, but that's just one example of a potential event that can cause an acute increase, especially as climate change becomes more relevant. And then finally, the relationship between PM2.5 and stillbirth among Black individuals varied by the zip code level income. And so we saw higher association in the lowest income zip codes. And so this is kind of showing as a proxy or indicator of potential other factors. So for example, if you're living in a lower income zip code, you may not have access to your own private transport and maybe taking public transport and be more exposed to traffic emissions, or your house within that zip code may be more likely closely located to an air pollution emission source. And so this may be one explanation. However, there's various other social determinants that may be explaining the modification by socioeconomic status. We're unable to determine for sure, but this definitely warrants further investigation. And then finally, we noticed the kind of reverse association or protective effect of PM2.5 and stillbirth among Asian individuals. A lot of previous research has noted this, that it may be due to higher levels of education, higher use of care. Another potential aspect is their geography within the US. So they were concentrated in a specific area mostly in the Western US. And so that may have had an effect. Additionally, they were a couple of years older than the rest of the population and had a higher average median income than other races and ethnicities. If you see at the table at the bottom, their distribution, they were much higher to fall in the highest quartile, greater than 50,000 as their annual income. So that may also suggest that their residents within zip codes may be further away from air pollution sources due to these differences by socioeconomic status. Okay, so I'll conclude with future work to build on this. This was kind of the first study with this data set. And so the air pollution data that I mentioned, the PM2.5 data, we also have the same information on nitrogen dioxide and ozone, which are other pollutants, but then can measure specific sources of pollution. So for example, NO2 is typically more associated with traffic pollution. So we plan to look at those concentrations and the association with stillbirth in the next analysis. Additionally, we may build on the work of other studies in the Environmental Health Department at Harvard that have looked at distance to fracking and mortality, and look at that as a source of air pollution and if that affects stillbirth. So fracking is a source of PM2.5 and nitrogen dioxide in specific parts of the US where there is unconventional oil and gas drilling. And then finally, looking at access to grocery stores or distance to grocery stores and fetal growth, so a different outcome, but whether or not that is modified by PM2.5. And so there's various parameters we can look at there. And that study would be conducted in Eastern Massachusetts and not nationally. So yeah, thank you for listening to my talk and coming today. And of course, thank you to Stefania, who is here, for all her support over the last few months, and also Dr. Sonia Hernandez-Diaz, who's also my supervisor, and then also the funder. So this is part of a T32 training grant from the National Institutes of Health. And I'll be happy to answer any questions.